The World Health Organization has just declared the Ebola outbreak in Congo and Uganda a public health emergency of international concern, its highest alarm level short of a full pandemic declaration. We're talking about 246 suspected cases, up to 88 deaths, a strain of Ebola for which there is no approved vaccine, and at least 6 Americans already exposed in the field. The CDC is now running active extraction operations to get American nationals out of the affected zone. Joining me now are Sophia Reeves, our economics and markets editor, and James Chen, our geopolitical analyst. Sophia, let me start with you. Is the WHO's response actually adequate here? Or are we watching the same institutional slow-motion disaster we've seen before?
Thanks, Emma. And the honest answer is, it looks worryingly familiar. Let's be clear about what happened here. The Telegraph is reporting that this virus was likely spreading undetected for 3 weeks before anyone officially raised the alarm. 3 weeks. In a conflict zone, with a strain that has no vaccine. The WHO has now issued its declaration. And yes, that triggers international protocols. But the question serious people should be asking is why the detection infrastructure failed so badly in the first place. Tedros and the WHO have spent years promising reformed, faster response mechanisms after the COVID catastrophe. And yet here we are, potentially 3 weeks behind the curve on an outbreak in one of the most porous, conflict-ridden border regions on the planet. Douglas Murray has argued for years that Western institutions have a consistent, dangerous habit of prioritizing their own institutional reputations over honest, urgent communication. And this situation has all the hallmarks of exactly that pattern. The fact that American citizens have been exposed and are now being extracted by the CDC is not a minor footnote. That should be the headline. And I would argue the Biden-era dismantling of pandemic preparedness infrastructure, and frankly, the chronic underfunding of biosecurity frameworks under multiple administrations has left the West dangerously exposed to precisely this kind of scenario.
But, Sophia, isn't it unfair to dump this on the WHO specifically when we're talking about a conflict zone where no international body has easy access? You can't exactly send inspectors into active armed conflict. And James, what's your take on this? Are we really facing a global threat here, or is the media framing outpacing the actual risk?
Well, look, I think Sophia's instinct on the WHO is right, but she's landing on the wrong diagnosis. The problem isn't just the WHO's communication culture. It's the fundamental economic and structural reality of how the world invests or doesn't invest in diseases that primarily affect poor, conflict-affected regions. The Bundibugyo strain has been known since 2007, nearly 20 years, and there is still no approved vaccine. Why? Because the pharmaceutical economics simply don't incentivize it. There's no commercial return on a vaccine for a disease that clusters in war zones in Central Africa. That's a genuine, specific market failure, and it's one that requires strategic state-level investment decisions that neither the US, nor the EU, nor the broader international community has been willing to make. The 2007 Bundibugyo outbreak had a case fatality rate of around 34%. We're seeing comparable numbers now. That data was sitting in the scientific literature for almost 2 decades. The risk here is that we spend all our energy attacking the WHO while missing the structural investment failures that created this vulnerability in the first place.
I hear what James is saying, but with respect, that misses the point entirely. Yes, the vaccine investment failure is real. Yes, it's a structural problem, but we are where we are right now, today. 6 Americans have been exposed. The CDC is running extraction operations, and the system that was supposed to catch this early failed. You can't address structural investment failures in the next 48 hours. You can demand that the institutions we fund, that we have poured billions into, actually do their jobs with urgency. The WHO had reformed protocols. They had promised faster response, and they were still 3 weeks behind the virus. That's not a market failure. That's an institutional failure. Full stop. And the idea that we soften that criticism because the geography is difficult, I'm sorry, but that's exactly the kind of excuse-making that got us into trouble with COVID, and I'm not buying it this time.
Here's what I want to know. 6 Americans exposed, active extraction underway, a virus with no vaccine spreading through a region that borders multiple countries. Where does this go in the next 60 to 90 days? James, where do you see this playing out?
The way I see this playing out there are really two critical variables. First, can Uganda's emergency response actually hold the line at the border? Uganda has a meaningfully stronger health system than DRC, and if they can implement effective isolation and contact tracing, the probability of a broader regional spread drops significantly. Second, and this is the one I'm watching closely, the extraction and quarantine of exposed Americans will be a real-time test of whether the post-COVID preparedness investments actually translated into operational capability or just talking points. If the CDC manages this cleanly, it actually tells us something reassuring about Western institutional capacity. If it gets messy, if there are protocol failures, if the quarantine infrastructure isn't where it needs to be, that's the scenario that gets very uncomfortable very fast.
Here's what concerns me most. The thing James isn't fully accounting for is the conflict variable. Ituri province isn't just geographically remote, it's actively contested. Armed groups operate throughout that region. Health workers have been attacked in previous DRC Ebola outbreaks. Contact tracing requires community cooperation, and you cannot build community cooperation in a war zone on a 48-hour timeline. If this virus smolders in areas that are effectively ungoverned, which much of Ituri functionally is, we could be looking at a months-long grinding regional crisis rather than a clean containment story. And the trajectory suggests that the 3-week detection gap we've already seen could repeat itself in new cluster areas. That's the scenario that should be dominating every security briefing in Washington and London right now, and I'd wager it isn't.
Sophia Reeves, James Chen, a sobering and essential conversation. One thing is certain. A virus that had a 3-week head start, no vaccine, and an active war zone to hide in doesn't care how long the WHO's committee meetings take.